Okay. I was just trying to get the chat room back up. So let me just see who we've got here. Okay, most of us are back. So we were talking about coverage, right? And this is the coverage for Part D for these different categories of medications, including psychotropic meds. And then this was an interesting point I wanted to bring home for you, that of the drugs that are covered by Medicare, Abilify and Cymbalta are amongst the top drugs covered by Medicare. So here, this column is the drug cost, how many people are taking it, how many prescribers are prescribing it, and the total claim count for each drug. Here's Nexium, which now is, with 2013, it's over the counter. Here's Advair, so COPD. Crestor, it's cardiac, but related to lipids, right? I think, I have to remember. And here's Abilify and Cymbalta right in the middle. Here's Spiriva, another breathing aid. And so Abilify and Cymbalta are the two psychotropic meds that fit in with the top 10 drugs covered by Medicare Part D. So a lot of patients are getting these two drugs, basically. Here's the numbers, look, over 1 million getting Cymbalta, and this is back in 2013, and not even 500,000 getting Abilify. Okay, so just thinking about costs and prescribing practices. So I will tell you that prescribers, as prescribing psychologists, are able to bill for Medicaid. And as I think you all know, we probably prescribe 2 or 3 times for Medicaid patients, Medicaid patients. I think it's 2 or 3 times more than psychiatrists do. This is the proportion of Medicaid enrollment and spending for enrollees with and without behavioral health care. This is from 2011, these data. And so these are the ones with behavioral health conditions. These are the ones that don't have a behavioral health condition. And this is, let me just see, because this is comparing, this is enrollment, right? So 20% of those enrolled have behavioral health conditions. But spending-wise, it's almost 50% of the money that goes to these patients. So 50% of patients with behavioral health conditions, so 50% spending for them, even though it's only 20% of the whole patient population on Medicaid that complained about behavioral health conditions. I think this disparity is probably even greater now. This was over almost a decade ago. Although wait, so this was published in 2015. But you know how that is. You collect your data, you analyze it, you write it up, you submit it, go through a revision or two. It takes time to get things published. So this was the proportion of adults with behavioral health conditions who received treatment. This is from 2015. And this is, whoops, sorry. Those with mental health disorders. This is substance use disorder, okay? And this compares the uninsured and the people who receive Medicaid, okay? So for mental health, the proportion, so it's about 24% difference between uninsured and Medicaid. about 11% difference for substance use disorders. Okay, so this goes over Medicare Part D in terms of drug costs, out-of-pocket expenses. This is current for 2020. And so you have your deductible, there's initial coverage, there's a coverage gap or the donut hole that they refer to, catastrophic coverage, and then when the coverage actually ends. Okay, so among adults who were denied coverage for a prescription drug in the past year, almost half ultimately didn't fill the prescription. So that's a kind of amazing statistic in my mind, right? If you, let's say, are schizophrenic, your insurance company doesn't cover it, half of the people in that situation just don't bother with the medication prescription. So with the Hawaii program, we used to have our students do the practicum while they were still enrolled in the program. And so they would present cases every week. So they were presenting cases for like, 8 months. But the thing that shocked them all at first, they were working in a community health clinic, and a drug choice would be made between them and their preceptor. And faculty who would review their cases, we would say, why'd you choose this drug? And the explanation was, they had samples in the cabinet. And that was how they sometimes chose the medication that was going to be prescribed. And in a community health setting, anybody can come in. If you have Medicare or Medicaid, that's one thing. If you didn't have insurance, they'd still see you. And the idea that medication choice was being made based on what they had in the closet are very realistic, but very eye-opening in terms of, we were talking about cost and things like that. It's sometimes very scary that the only thing that you're going to put a patient on is something that a drug rep dropped off because they can't afford to buy the actual medication that will help them. So just something to think about as you go forward in your practice. All right, so these are from Bob McGrath. I think I've updated them a little bit, but he calls them stupid drug tricks. And it's really very eye-opening in terms of decision-making based on presentation about a drug. Okay, so we're looking at this slide. This is from 2001 on venlafaxine versus SSRIs. So you all remember we were talking about positive placebos or active placebos last time we met. So here the active placebo is SSRIs, and they compared a regular placebo and the venlafaxine. And these are data that were published in the British Journal of Psychiatry. But you'll see data that looks like this again, and we'll talk about that when it comes up. So what do we have here? This is weeks of treatment, right? They're using the 17 question HAM-D, and this is remission. Let's see if I'm reading this right. So it's those who had a score of 7 or less on the HAM-D 17. Okay, so pretty much the same here. At 2 weeks, there is a statistically significant increase. Now, this is just doing, I think, a t-test is what they used here. By week 3, you see that every group is increasing, right? Your placebo remission rate, your SSRI remission rate, and your venlafaxine remission rate, all going up. And to me, that's a very interesting phenomenon in and of itself, that by the time you get to 8 weeks, you have, what is it, like 25, a quarter of your patients in the placebo group are going into remission, right? So I don't know why we can't prescribe placebo, but it sure seems to work pretty well. But as the authors claim, not as well as SSRIs and not as well as venlafaxine. Okay, so those are the data as published in the literature. So same article, they looked at response rates. Now here, we're looking at different scales. Here they're using HRSD 17, 21, and here's MADRS or MADRS. And so they're looking at how do you define remission, okay? So here, they defined it as 7, right? HAM-D17 less than 7. And here, if you look across the different tests, whether there's 17 question, 21, depending upon how you define remission, you will see more statistically significant findings, okay? So this looks like it's true pretty much across the board. Oops, sorry. Pretty much across the board for whatever cutoff you're using. And they illustrate here that no matter what measure you're using as remission, you're still seeing statistically significant increases in the venlafaxine group and the SSRI group relative to the placebo group. But look at this. And it doesn't say, I can't remember if this is percentage, but look at this placebo group, right? Now, I think you might remember from last time we met, I talked about historical controls. So sometimes in the literature, I'm not saying this is, but if you look across here, there's some uniformity in the placebo response, right? But then there are these outliers. There's this one, there's this one, there's this one, right? So in some instances, they would allow you to do a pooled placebo group, right? Because that would take care of these intergroup or intra-group variations. But they didn't do that here. But what they're doing is they're doing these comparisons between placebo, SSRIs, and venlafaxine, and they say that it doesn't matter what we use to assess remission, venlafaxine was always statistically significant, okay? So that's the data. Now, here's another, the same study, no, different study, different year, okay, so 98. So here they're looking at venlafaxine in different doses, and one of the main adverse reactions to venlafaxine, which is a change in supine diastolic blood pressure. Okay? So they looked at different groups according to the dose. Okay, so here we have placebo is the orange one. And as we've seen already, there is a rise in the placebo group. And this is again on the supine diastolic blood pressure. But compared to, here's venlafaxine less than 100. The green is venlafaxine 100 to 200. The turquoise is venlafaxine 2 to 300. And then this is greater than 300, okay? Now the biggest group that they had was the green one, the 100 to 200. And that's over 1,000 patients in that group. So what do you see? You do see a large increase and early on for the patients who are getting venlafaxine at doses greater than 300 milligrams. Now, this group is much smaller than any of these other groups, right? They don't even tell you what the placebo number is, and I'm sure it's in the paper. But the point is, they are trying to illustrate that there's a statistically significant increase after 3 weeks, basically, only for the 300 milligram group. Now, it's going to depend on what kind of analysis of the data that you use. If you use t-tests, you know, that's you lose all credibility right away for multiple points. And I think multiple regression analysis might be more appropriate for this, because certainly, you know, with ends of this size, right, 900 people basically versus 500 people, you are going to be seeing statistically significant differences between these lines that are down here and these lines that are up here. Now, it's interesting to me that they chose to plot the placebo and the venlafaxine less than 100 in colors that not just complement each other, but are similar. So it's kind of hard to distinguish with the eye between the orange and the red lines. Similarly, here they have turquoise and green. Now, they could have used the dark blue color. They could have used a lot of other kinds of you know, color differences so that you could really see the differences between the 100 to 200 and 200 to 300 groups. But they didn't. They kind of lumped them together, right? But my feeling is that you probably are going to be having some differences in these lower dose groups. But they were trying to emphasize that if you stay away from 300 milligrams, you're not going to have a statistically significant rise. Now, this is patients who develop the elevated SBDP, right? So they're defining what elevated SBDT, I'm sorry, I'm stumbling on my initials, SBDP, it's easier to just say it's supine diastolic blood pressure. But they're basically saying that you don't have to worry about doses other than 300 or greater. And in doing that, what they're saying, they're trying to convey is that there is not a difference between the controls and the doses up to 300, okay? Now, these are not huge numbers. These are percentage. And so even at the highest point for venlafaxine at 3 weeks, it's 10% of patients who developed that elevated blood pressure. So they will use the 300 as a therapeutic threshold. So just before I skip to my other slides, you know, so the point of this series is when you're reading the literature, you need to check as to how the data are expressed. What are the statistics, right? I mean, they have a star here that says P is less than 0.001, and that's compared to the placebo group. But they don't report if there's a difference between the lower dose venlafaxine and this high dose. So, you know, so you have to eyeball these data always, and I don't care if it's because of bias associated with the drug companies. I don't care if it's because you have a bias because you want to publish the paper, and so you tend to look for data and outcomes that are going to favor your thesis, your hypothesis, or you're trying to get more people to take the drugs. But when you look at these data, you have to discern what is really going on. Okay. I'm going to talk about some pregnancy related regulations. That the coding for pregnancy risk has changed, and I'm not sure. Do you all know about that? I don't know who. That would have been Dr. Strada. Now, Strada did. That would have been Dr. Brady's lectures. Did he talk to you about the new pregnancy categories? Yes, no, maybe? No? Okay, so anyway, so we are going to be talking now about pregnant women, some of the risks that are out there with them taking medications, and the new guidelines. Okay, so what astounded me, and this is from uspharmacist.com, and if you don't visit this journal frequently, I highly recommend that you do. They have some of the best summaries of everything and anything that's going on in pharmaceutics and in pharmacology. And I think that they have great, they simplify topics. But when you're getting ready to take the PEP, for example, any topic that you're looking for, I would go to uspharmacist.com and see what you can find, because they really do a beautiful job of summarizing. And I think we have 2 pharmacists in our midst. So maybe you guys want to say something about that. But I find it a really good starting point when I want to know about a class of drugs. I want to know about special populations. I want to know about, adverse reactions to certain drugs, things like that. It's always a good resource, in my opinion. So anyway, so 90% of pregnant women take at least one medication, and 70% take one or more prescription drugs, okay? So to me, that's astounding, right? 90% of pregnant women are taking at least one medication, could be over the counter, and 70% take one or more prescription drugs. It's just amazing to me. So, I mean, I'm not judging them. I think it's a testament to the fact that there are very good medications out there that are safe to take while you're pregnant. But it just really surprised me, that number. So one of the reasons why this is a special population is because we have physiological changes in just about every organ system during pregnancy, and that alone can affect the kinetics of the medication. Remember, pharmacokinetics is how the body affects the drug, right? So every organ system in the body, including the brain, changes in function. There was a study, this is so many years ago now, that pregnant, the study was first done in animals, and then they verified it with fMRI. So in the rodent brain during pregnancy, there's about 3 million new neurites that are formed in the pregnant brain within the first, trimester. And I just think that's astounding. And what they discovered later was that it's the progesterone that is actually protective of brain tissue, which we all know, but it protects the brain and stimulates neurite growth. And I just think that's amazing. But it's true that just about every organ system in your body is going to respond differently to medications, or medications are going to act differently in your body when you're pregnant. The pregnant women have a 40 to 50% increase in blood volume, leading to larger volumes of distribution and potentially subtherapeutic levels of drugs if they're hydrophilic, right? So we all know about hydrophilicity, and if you are taking a drug that's hydrophilic, then it's probably going to get cleared faster and earlier, right, in your other organ systems before it gets to the brain, as well as, it's probably affecting hydrophobic compounds as well. But hydrophilic drugs, it's all of our neurotransmitters are all very hydrophilic, right? And so this increase in blood volume alone can contribute to what happens to hydrophilic drugs. Pregnancy is associated with increases in CYP, CYP enzyme activity. So then you could be metabolizing things more quickly. GFR rate increases by 50% during pregnancy. And as you know, there are a number of drugs that are going to depend upon how the kidneys are functioning in terms of how the drug is going to clear. And then we have 65 to 70% of all prescription drugs are assigned to category C. Now that's the old category, but they have drastically different sets of supporting evidence and risk. So a lot of times a drug will just get tossed into Cat C without you really knowing the data that's responsible for that outcome. And so when you're reviewing the literature, how many of you have pregnant patients or have had pregnant patients? So you can just type yes or no. But you certainly need to know about all of this for the PEP exam. But in addition to that, you need to know if a drug that you're prescribing, if it's in the old Cat C, what's the basis of that classification, okay? So this is from US Pharmacist again, the same article, but this is on the pregnancy subsection overview of the new requirements. And now we're going to look at fetal risk summary. We're going to look at lactation issues. And so this is really for the fetal injury to the fetus, okay? So this section that they've developed is going to look at what happens to these drugs. Is it at risk for fetal injury? And how many risks are there? Is it more than one? So, you know, with acetaminophen, high doses of acetaminophen can cause cardiac abnormalities in the fetus. We have all the known liver effects. And so there's a number of systems that can be affected by acetaminophen. And so that data will be considered in there. And then you take into account inadvertent exposure versus prescribing decisions that you make for the pregnant patient. And so if you're going to be prescribing a medication, you need to weigh all of these factors that are here on this slide. So I may have told you about my student who was in Guam. She did her practicum at an outpatient clinic as well as inpatient psychiatric hospital. And she had a patient who was schizophrenic, a lawyer, so a smart woman, schizophrenic, and she got pregnant. And she didn't even know she was pregnant for a while, and she was taking Lamictal. Now, my student obviously didn't prescribe it. The psychiatrist had prescribed the Lamictal, and she was doing okay with it, you know. So she decided, the patient decided to wean herself off of the Lamictal, even though she was doing really well on Lamictal, because with bipolar elements to this patient. And so she weaned herself so that right before delivery, she had stopped taking the Lamictal. So she was worried about what would happen when she breastfed, because Lamictal does appear in breast milk, right? So because she was already a few months pregnant when she realized that she was pregnant, she decided not to stop the Lamictal outright, right? But she weaned herself off over the 6 months so the baby would not be going through a withdrawal reaction of any kind. And she was fine. Now my student left Guam, so I really don't know how much of a follow-up there was after she left. But, you know, 6 months later, she reported that the patient was doing really well. so of course, you have to weigh that. You have to do that risk-benefit analysis because that patient, going off Lamictal is going to increase the risk of postpartum psychosis, right? Not just depression, but psychosis. And that is a real phenomenon and a real risk. And so, but my student and the patient worked it all out, and they walked through all the scenarios. I mean, I said, well, she's on, the baby's getting Lamictal, so it'll, not have seizures. But she was just concerned. She didn't want to be breastfeeding the drug to her baby. And so they walked her off the drugs. So you will have to make that decision each time. I don't see anybody typed it here. Let me see if I have to, there, I don't know what that is. All right, so some of you have. So Eddie, I'm going back to your question up here. I didn't see it before, but no, they were talking about a prescription medication. They were not talking about over the counter. So I don't think vitamins and supplements were included. I can go back to the paper and check it out. All right, let me go back to sharing. Hopefully I can see your comments. They just disappear. There it is. Now I got it. Like magic, I got to go in and out of share a couple of times. And presto. Anyway, so these are all factors that you're going to take into account. And then what's the level of data? Okay, so is there human data? Is there animal data to support it? What's the level of knowledge for that? So when we're talking about breastfeeding, this is the new section, right? Lactation. Here, I'm just going to go back 1 sec. Sorry. Okay, so this is the pregnancy subsection overview. And then this is the section that's now called lactation. And so then they do risk summary. They do an analysis of is the drug present? If it's not present or it is present, what do you have to take into account? What's the effect of the drug on the breastfed child? And so these are the considerations that you have to make. Okay. All right, and then this is the change in the labeling. This is from a couple of years ago now. This is out of FDA. And this is for prescription drug labeling sections that are for drugs used in specific populations. Used to be labeled like this, and then as of June 2015, they changed the organization. So pregnancy includes now labor and delivery. Lactation includes nursing mothers. And then the new section, female and males of reproductive potential. And so that's going to be a sperm count. It's going to be any genetic malformations that may take place as a result of affecting the male or the female. Okay, so these are the all new drugs have to be evaluated for these categories. Okay, so we no longer use A, B, C, D, X, but of course, and I have to ask them on the PEP if they're using X, the alphabetical scale, or they're using the numbers now for the PEP exam, because I have a feeling they're still using this one. So you kind of want to know both. Okay. And so here's what happened. They replaced the letter category. Pregnancy now includes pregnancy exposure, and there's a registry. So for Lamictal, for example, there is a Lamictal registry for pregnant women. Risk summary, clinical considerations for lactation, same things that you want to figure out. And then for females and males of reproductive potential, pregnancy testing, contraception, and infertility. Okay. This is just in case you're not familiar with the Hale and Rose lactation categories. These are some of our drugs that have been put into these different categories. So L1 is a lot of data. L4 is no data and possibly hazardous. L5 is limited data and hazardous, okay? So they categorize it by antidepressants, mood stabilizers, antipsychotics, psychostimulants, and sedatives and hypnotics. So these, you know, this is nice and easy for you to remember which drugs are L1, which is the category that you would want most of your drugs to be on. And the idea that just about all these other drugs here are not is kind of amazing. So, okay. Now, this is a list of teratogens and developmental toxins. That's the other name that you might hear. And it's a long list. These are not all psychotropic drugs, but some of them are. Here's lithium. Here's phenytoin, warfarin. Let's see what else we have. Here's tobacco. Here's ethanol, hormones, androgens, no, estrogens out there. But anyway, so this is a list of unsafe medications for pregnancy. And you should be familiar, well, not just pregnancy, but because of the risk of teratogenic events. So I pulled this information off of a emergency medical website because although you may not ever need to address this, because if you have a patient who's having a problem, you're probably just going to call 911, right? But I think it's really valuable for you to be more familiar with this information. This is for pregnant women, and depending upon the category, what is your go-to medication? What is your second line medication? And what do you definitely want to avoid? Okay, so this is if a person's having an airway problem, if it's breathing problem, circulatory, GI, and the next couple of slides continue on. But I think as future prescribers, it's really important for you to know what your first line is going to be and what your zero line is going to be. And so, for example, here you have for hypertension, you have hydralazine, but you want to avoid ACE inhibitors, ARBs, or aldosterone antagonists. I gotta drink some water. All right, so I think this is a useful piece of information for all of you to have. It might go a little beyond, above and beyond what's required of you to take the PEP, but I really think that it's very valuable for you to be familiar with what drugs in an emergency are going to be considered safe and what drugs do you really need to avoid. Okay, so this is the neuro section. So if there's a seizure, if the patient needs pain control, if there's a headache or a migraine. So you can use benzos. Here's lamotrigine, magnesium if it's peripartum, if the baby's about to be delivered. Here's your second line, but here's your zero line. Do not use these drugs. Valproate, carbamazepine, phenytoin, and phenobarbital. So I think it's worthwhile to know in a pregnant woman who's starting to seize, you want to make sure they're not on these drugs and that they're not being given. Now here's aspirin and NSAIDs. That's kind of obvious because of bleeding, right? So they say acetaminophen. And then if you still need something else for pain, opiates and fentanyl. Now, in this instance, fentanyl would be a perfect drug because it's so potent. You just give a tiny little bit, right? But if this person is addicted to opiates, do not do not give more opiates, no matter what you do. And here's headaches. So let's see. So you can use intranasal lidocaine, which is interesting, but don't give ergotamine. You know, ergotamines are going to cause additional vomiting, so you want to avoid that. And then let's see. This is for given micro, they call it microbiotics, but it's not microbiotics. It's medications that you might be giving that can have adverse reactions, and these are your classes. And then here's endocrinology, hyperglycemia. Here's a thyroid storm. You know, so I find this all very interesting and useful for you to have. And here's your psych. Don't give a pregnant woman lithium. Okay. Here's anticoagulants. Don't give them warfarin. Here's an overdose. So you can give them opiate antagonists. And then do not give penicillamide. I know, penicillamine, I'm sorry. Not sure why you would, but don't give it. All right. So I'm going to talk to you now. This is kind of an extension from the venlafaxine data we were talking about before, but we're going to talk about accurately estimating drug effects. So as you saw when we were talking about the Thames studies, that there's ways to get your data to look pretty. Now we're going to talk about accurately measuring drug effects. Now, these slides are a few years old. I think I updated them maybe 3 years ago, but the point will be well taken. So we have Abilify. You have a patient who wants to take Abilify. So you go to the website, www.abilify.com, right? And here's what the front page looks like. It's a group of people, right? Kind of hanging out in nature, it looks like. Kind of fades off. And this guy's looking at this person, and, you know, so are they interacting? It's not really clear. But it promotes the idea that this medication will help you move forward, right? And a big part of what moving forward means to a lot of people who are bipolar is being able to interact with other people more. So Abilify is approved by the FDA for acute bipolar mania. You have all of your links here, what you can expect with Abilify. Talk to your healthcare provider. Get the most out of treatment with Abilify. Information specifically for healthcare providers, caregivers roadmap, right, and press releases. So nice, pretty page. So if you click on the link for healthcare professionals, you then have efficacy. Here's some options. Unique pharmacology, efficacy, I'm sorry, I can't read the small ones right now, tolerability and safety, dosing, and managing expectations. So if you click on efficacy, what'll come up is symptom improvement. So this is the data that they present on symptom improvement, okay? So let's look at that for a second. Here's the PANSS total score, right? And this is Abilify 15 milligrams. This is placebo. There's a big difference between the two. So let's think about what that really means. So, okay, we got a couple of minutes. We'll take another break and then we'll be done. We'll finish the last hour. So here's the PANSS total score. So the total score includes positive and negative symptoms, okay? So this is the mean change from baseline at the endpoint for both of them, okay? So this is risperidone. So here they're using risperidone as an active control, right? And regular old placebo. And then this is Abilify. Now this is 20 milligrams. Just to remind you, what we were looking at here is 15 milligrams. So that's, now we're talking about 20 milligrams. And The mean change from baseline is, let's say, minus 14, just for the sake of eyeballing it. Here, and right, that's negative, yes, I just want to make sure. So here's risperidone, 6 milligrams, and the change score is a little higher, right? Here it's maybe 15, but really no difference, right, between the two. So when you break it out, here's the positive score summary and here's the negative score summary. Now they're using colors that are very similar, which is never good for graphing, is your placebo, right? So there's a gradual decrease in placebo. Gradual decrease in the change score. So bigger or better changes, right? So that's your placebo. And then here we have the pale blue line is 20, the dark green line is 30, and the paler green line is the risperidone, 6 milligrams. So what we're comparing here is all these different treatments, and basically what they're saying is there is a difference between Abilify at 4 weeks and Abilify at 30 milligrams compared to these other doses, as well as compared to the control. This is your negative scores, and you know, it's interesting that there's a slower change or a dip in the change, but basically your groups end up the same here, but compared to placebo, statistically significant. And so they're saying that 6 milligrams of risperidone is basically the same as 30 milligrams of Abilify. Now, when we talk about the PANSS, we have to, it's an older test. It has 30 items on it. 16 are psychopathology symptom items, 7 are positive symptoms, 7 are negative. The physician completes it, and each item is scored on a 7-point severity scale. So a patient with schizophrenia that's going into a clinical trial will have a score around 91, okay? Starting 91. And these are some of the symptoms that are included in these different components of the test. So when we're looking here, right, and this is the total score, and this is the change. This looks like a big difference, right, from here to here. These are the data that they actually present. These are the data that you have to read deeper to find an explanation for. So after 4 weeks, Abilify reduced the PANSS score by 14. That's 15% of 91. Positive score only improved by 5 points. Negative score only improved by 3 points. So where are they getting 14, right? About half of the effect had to do with the general symptoms. So half of the effect, I'm going to just skip back to this page, really didn't see a major change for positive or negative symptoms, but you saw the change in the general symptoms. Okay, so are you really treating schizophrenia with this drug, right? Because you're helping maybe that the patient is more cooperative or better oriented, less anxiety or tension, things like that. But in terms of the schizophrenia, it's a modest change. Okay. And so when you're looking at those data, one, you have to pull out the actual data to take a look at it, and so don't assume that the change that they're saying is a change, okay? Or it's not the change that you're looking for, right? Okay, we have a choice here. Let me just stop share for a second. I don't have a lot more slides. So we can either just keep going and then we end early, or we can take the break and go forward. So everybody, I'm not sure which slide, Jason, but end early. Okay. Anybody else? Does anybody need to go to the bathroom or do something right now? Oh, thank you. All right. So
if I may, then in that case, I would run the poll right now, the attendance.
sure, go ahead and do that. Yes, I do have a study guide, Rebecca. I'll make sure Aiden puts it up. So just do the poll so we know who's here. There's 26 of you are here, so. Yeah, I don't really have questions embedded in this slide set. I always thought I did, but I must have moved them around. So participating in the poll is very important. There's still a couple of people, I think, who have not answered. Oops. And you can't get credit for this if you aren't answering the poll. So try to get your answer in. Okay, I'm going to keep going forward. You can still put your answer in if you want. I think it's pretty close at this point. Okay, well, let's go back to my slides. All right, so anyway, so here's the HAM-D score. They did a mood score. And this is going from 2.4 to 3.5 on HAM-D. This is going from 0.4 to 0.5. You can call that an improvement, but doesn't take much to get this guy golfing again, is the conclusion. That he didn't need much of anything, and maybe not 30 milligrams of Abilify. But so those are just some things to think about. Now, the next series of slides is really related to what we covered when we talked about depression and the STAR*D trial and all of that. So most of these slides are criticisms of the published literature in psychopharmacology and the influence of the drug companies on outcome. So greater risks must be offset by greater value, right? And so this is going back a while, but among drugs FDA approved from 75 to 99, 8.2% acquired an additional black box warning and 3% were withdrawn. Now, we do have more black box warnings now, and I don't think they're always fair. So, you know, the warning about suicide in young adults with any antidepressant, basically, I think is a little unfair. But, you know, I think that there are some of our antidepressants that really have very low risk for suicide, but we include it on everything. Half of serious adult overdoses, this is old data, but involve tricyclics. Now, it is hard to overdose on most of your psychotropic meds, including and maybe especially your antidepressants. But there's always a risk. I mean, you can cause liver failure if you take too much of anything. So it really isn't a lot of literature saying that antidepressants cause, you know, or induce mortality, right? And that is one of the arguments that these authors were trying to make, that most of adult overdoses, half of them, involved antidepressants, but what's a chicken, what's the egg, what's Bradford Hill have to say about that, okay? So therapy can be at least as effective as meds. So these are some conclusions as to why give medication, right? So, and we went over some of this. Antonuccio, we talked about this before. Therapy is equal to or better than medications for depression, even severe depression. You get a mean change for treating cognitive problems in schizophrenia with, this is your point estimate. Medications, 0.22, cognitive rehab, 0.45. So this is suggesting that for treating cognitive problems, you're better off with rehab, right? Behavioral rehab. And then increasing evidence is that the total cost for therapy is cheaper for depression and anxiety disorders. And you know what, that's going to change as more drugs become generic. So it's kind of a, I don't know if it's a realistic argument against it, but this is a comparison. Not a lot of data to support this either way, but suggesting that your effect size is better for therapy than meds, the valence or variation therapy is equal to meds, the duration that therapy will last longer than meds, penetration, therapy is less than meds, benefits, costs, risks, so is therapy better than meds? Now, I have always told MSCP students that medication is the last tool in your toolbox if you have a patient come in who's willing to talk to you. If that patient is not willing to talk to you, then medication becomes perhaps your first line treatment. But otherwise, if that patient is willing to work on their stuff and don't need medication, that is always going to be the path that you follow. And it's when the person is in so much pain or suffering or apathy that they just won't even talk about it. That may be when you need to start that patient on meds. It doesn't mean you have to keep them on meds forever, although a lot of people do stay on. If they've got an antidepressant that's working, even if it's a placebo effect, they will keep taking that antidepressant. Okay. So this was a large meta-analysis. This is from the British Medical Journal. They concluded that there was no difference in response or remission rates from second-generation antidepressants and those achieved by cognitive behavioral therapies in the treatment of major depressive disorder. So that did come out a few years ago. There was another study that came out, I think just 2-3 years ago, basically saying the same thing, that CBT is as effective as medication, but my recollection was that it was for mild to moderate depression. So, but the jury is out in terms of which is better, right? I mean, obviously behavioral therapy, the number needed to harm is like infinity, right? But does it always work? And are people always willing to talk? Those are the questions. Okay, so here's the informed consumer. I think you guys know all of these things. You want to look for many studies. You want to look at the sample size, dose, dose response curve. You want to look for choice points, choice of statistics, choice of cut points, right? So if you think back to the venlafaxine, where do they cut off the data? Where are they amplifying a small difference, right? And then be leery of any findings using non-standard methods. And that means you need to know what the standard is, right? And you have to do your research. You monitor your own personal use of medication. I mean, I'm an open book with my meds, but how many, what percent are on prescription drug, how many you're what are you taking, how many you're taking multiple psychotropics. And this is for you as a prescriber, not your personal medications, but it's, you know, in your practice, are you prescribing an SSRI to just about anybody who comes in, right? You may want to take a step back and look at your success with your behavioral methods before you continue on that practice. So the idea that you would monitor yourself, it's a really good one. You want to know the answer before anybody else does, right? Anecdotal evidence suggests prescribers grossly misestimate their own use of medications, and so it's good to have that checked for yourself. And then recognize cognitive errors, so covariance misestimation, post hoc, ergo propter hoc, and then lack of exposure to placebo responders. So these are arguments. I'm not saying they're true or not true, but I think that it's a good idea for you to keep track of what you do. And I will say, you know, I was a bench scientist before I started working at the law firm, and I see a lot of people who don't really want to look at the data. They're just like, okay, give it to me. I have a friend who just passed the PEP, who was one of my students, and he got like 14% correct on the methodology and research questions on the PEP. And I said, oh, we should have, you know, spent some time going over that. He said, you know what? I don't care. I don't like that stuff. I'm never going to think about it. So some people have that attitude, you know, but in my book, I think that you should arm yourself with that knowledge, for whether it's for your patients or for critics of your practice, and just to be aware of the kinds of errors that may be appearing. We don't do studies. I mean, we as the field of clinical psychopharmacology, we're not researchers, and it's unfortunate because I think you all know about the specialty petition, and the area where we take the largest hit every time is the fact that we don't have a lot of research substantiating our successes. And so I hope that for those of you, especially folks with PhDs who have done a thesis and had to use statistics, that you continue to keep an analytical view of your performance, and that you're able to come up with some data that will be meaningful to you and your patient population. So here's the clinicaltrials.gov site. Always refer to Cochrane reports. Carlot has a report. Stephen, Saul has lots of good resources out there for you. So use your resources for collecting information for your patients, for analyzing your success with your patients, and for critiquing the literature. And I think that's it. So we did okay on time. So did anybody have any questions other than, yes, I'll have a study guide put up, and Aidan, do you know what the due date is on the exam?
Usually we give like 2 weeks from the time that the exam is posted.
Okay, and when are they meeting with Dr. Brady next?
So Dr. Brady class gonna be April 4 and 5. So I think I'm gonna set the exam as well as the between weeks activity for April 3rd.
Okay, so everybody got that? And of course, if you have any problem with that, you'll let me know. But is there an assignment? I think it's just taking the exam. is my assignment. Is that correct, though? Does Dr. Brady have a assignment for next week?
Yeah, as you wish. I mean, if we don't have any between weeks assignment for this 28
Yeah.
that is coming, then that's going to be only exam.
Okay. There will be a oh, hold on one second. There will be an assignment. I'm going to talk to Dr. Brady as to whether it's from me or from him. Okay?
Okay.
I'll give you the two breaks. No spring break for us, unfortunately, Eddie. But take care. If anybody, thank you for those who already said you want to start PEP training. But as we get closer, those of you who do want to do practicum, of course, COVID's going to define that, but you know, basically from the time you finish class, you have a year before you have to graduate, okay? So even if you graduate in May and this is still going on, it's possible that you could do the physical assessment practicum, let's say in the fall or the spring of next year. So if you have any questions about that, you'll let me know, okay? All right, no other questions. We're dismissed. This is great time spent with you all. Thank you for your dedication. Thank you, Aiden.
My pleasure.